It's Friday night. The house is quiet, you've stopped moving, and the weight of subtle changes you've noticed in your child's behavior is surfacing. Lying awake wondering if your child is okay is not paranoia. Your instinct is a biological signal worth trusting. Decades of pediatric research consistently show that parents are the earliest and most accurate detectors of shifts in a child's mental well-being. Teachers and pediatricians only see your child in specific, structured environments. You see them across every context, especially at home where they feel safe enough to stop masking their emotions. Your gut feeling isn't an overreaction. It's an observation based on years of daily context that a clinician simply doesn't have yet. The signals are often quiet. A child who traditionally sleeps well is suddenly waking up frequently. A teenager who usually talks about their day stops speaking altogether. A previously social kid withdraws from friends. They start avoiding school, or they experience heavy emotions that they simply cannot articulate. This is where the self-doubt trap begins. We naturally try to minimize these warning signs by telling ourselves we're being dramatic, or that it's probably just a phase. That self-doubt is often reinforced by well-meaning friends and family members who suggest you should just hold off and wait to see what happens. This chart shows the parental doubt loop. Questioning your own instincts leads directly to delayed action, which puts you right back at the beginning of the cycle. This hesitation traps families for months. You end up waiting for those minor behavioral issues to become undeniably severe before you feel justified in seeking support. Breaking out of this cycle early is how you prevent those building behaviors from escalating into a situation that requires crisis intervention. You do not have to wait for things to get worse. The most effective window for intervention is the exact moment between "I notice something" and "this is an emergency." Let's evaluate the actual outcomes of the wait-and-see approach by looking at it through a return on investment mindset. The immediate input of waiting is zero effort. It provides the short-term benefit of avoiding the logistical hurdles and perceived stigma of finding a therapist. This graph charts the escalation of distress versus the cost of intervention over time. The zero-effort input creates a flat line early on, but beneath the surface, the unaddressed distress steadily grows. The first major trade-off of waiting is that emotional distress compounds. Unhealthy coping mechanisms can become set behavioral patterns. The secondary cost is relational. As time passes without adult intervention, your child's underlying trust in their family's ability to support them can begin to diminish. Look at the spike on the right. Delayed action increases the statistical likelihood of eventually requiring high-stakes, highly disruptive crisis care. Waiting is an active gamble that compounds the emotional severity and the financial cost of the eventual treatment. The alternative is a model like MentalSpace School, designed to remove the specific cost and scheduling barriers that usually keep parents in a wait-and-see mode. The required input for this approach is simply overcoming your immediate hesitation to book a single 50-minute exploratory session. This table compares the intervention ROI directly. When you stack wait and see against a 50-minute baseline check, the differences in inputs and outcomes are stark. The most valuable outcome of that 50-minute check is acquiring immediate, definitive baseline data from a licensed professional. That baseline data either provides clinical reassurance that your child is developmentally normal, or it establishes a proactive early action plan. Historically, long waitlists have blocked early action. MentalSpace addresses this by offering same-day teletherapy access, turning weeks of waiting into immediate support. It also removes the social stigma. Telehealth means zero waiting rooms and zero neighbor sightings. The session happens privately in your living room or your child's bedroom. Telehealth has changed the math of early intervention. Getting a baseline now takes less time and effort than managing the fallout of a worsening crisis. To make a decision, we need to analyze the financial input and how this model interacts with your insurance coverage. This graphic shows the breadth of accepted networks: Blue Cross, Cigna, Aetna, United, and others. Medicaid coverage results in a $0 copay. This reduces the financial barrier to a standard insurance copay, or exactly $0 out of pocket for Medicaid patients. There are hard constraints. MentalSpace School services are exclusively restricted to K-12 students currently residing in the state of Georgia. The second trade-off involves your environment. You save on the commute, but you must guarantee a private space where your child feels safe speaking to the screen. For parents who meet the geographic criteria in Georgia, The traditional financial and logistical barriers to a mental health evaluation have been largely eliminated. Based on your household resources and the urgency of the behaviors you are observing, it is time to map out who should take action tonight. This quadrant chart maps profiles. The bottom axis tracks logistical resources. The vertical axis tracks urgency of signs. If you're in this lower quadrant, noticing early, subtle changes, you're the exact fit. Look elsewhere if outside Georgia, or if your child requires hands-on, in-person psychiatric evaluation. If you are a fit, the absolute smallest possible first step you can take right now is to navigate to the MentalSpace School website and verify if your child's school is a partner. Information is the first step. If your instincts are firing tonight, gathering that information shifts you from worrying in the dark to taking measurable, low-stakes action.